what's your indication for starting pressors in septic shock?
For me, the indications would be someone who has refractory hypotension, meaning who is in septic shock and has a blood pressure that will not respond to appropriate amount of fluid.
Okay, so while we could take 2 hours talking about this conversation, how do you determine appropriate amount of fluid?
About 30 cc's per kilogram, so about 2 to 3 liters, I would say. And you can determine their response using some clinical indicators like their mean arterial pressure or sort of their turgor, I guess, but that's less clinically sound.
Yeah, so I'm going to agree with a lot of that, but not quite all of that. Okay. So the 30 cc's per kilo number is a starting place. Out of interest, do you know how we came up with that?
Well, I think it's sort of one of these Gestalt numbers.
Right, we made it up. Right, there's no unlike a lot of things in sepsis data. There's no data per se on 30 cc's versus 20 versus 40. 20, it could be like 1.5 liters, and that seemed too much. 40 seemed like it could be 3 or 4 liters. That seems like it might be too much, and so we end up with 30 cc's per kilo. There's no data behind it, but that's a starting point.
Okay.
So if you look at the sepsis bundles of this, or SCP-1, however you resuscitate somebody, you start with 30 cc's per kilogram. But understanding is different based upon where the patient is. If you have somebody who's in septic shock because of a perforated bowel and they come in profoundly dehydrated because they haven't been eating for 4 days, is 30 cc's per kilo going to be enough?
No, probably not.
Right, so that's not the time to start them. So 30 cc's per kilo is your starting point, and then you're supposed to assess their volume status. Again, how we assess for volume status is totally a conversation for another day. But you basically are supposed to start them on pressors once you perceive that you've adequately intravascularly tanked them, however you perceive that you adequately intravascularly tanked them, and then you start pressors. So what pressor would you start?
I would start Levophed in general for a septic patient if I've met all the criteria.
Okay, I agree. Why?
I think there's some good data to show that, or some adequate data to show that Levophed is a good first-line agent in sepsis specifically.
So, sort of. So ultimately it gets to the question of, and we're not going to spend a huge amount of time about this because we're trying to get to how you're supposed to treat somebody. What are you trying to do by starting somebody on Levophed?
Raise their mean arterial pressure, or improve their improve their vascular tone.
Those are side effects of what you're trying to do, but that's not actually what you're trying to do. What
Okay.
are you actually trying to do? You're
trying to perfuse them.
You're optimally trying to perfuse them, right?
Yeah.
So if you have somebody who comes in and we're grading and somebody has a gunshot and they're pouring out blood, if you put them on Levophed, will you increase their tone and will you increase their mean arterial pressure?
Yes, but
that's not increasing their perfusion.
Correct.
So your goal for everything you're trying to do within any shock state is to optimize perfusion.
Okay.
Sometimes it's with volume, sometimes it's with pressor, sometimes it's with inotro, sometimes it's with a physical thing, pericardiocentesis or everything. So you're trying to optimize perfusion. And when you have low vascular tone, the first thing, when you're dry, typically in sepsis you're going to be dry and you're going to be vasodilated. So the first thing you do is you tank them to their full.
Okay.
Because a lot of times that's all you need to do. And then the blood pressure comes up. If that doesn't work by whatever means you now have somebody who's still vasodilated, they have adequate intravascular volume, now you want to bring up the mean arterial pressure. The reason you want to bring up the mean arterial pressure is to optimize their perfusion. And because there's a lot of different ways you could bring up the mean arterial pressure, ideally, if you could design your perfect pressor, what would it do to your vascular tone? What would it do to your cardiac output?
the ideal pressor would, I guess it would increase your cardiac output and your tone to a point that doesn't also tip you over into lack of perfusion.
Right. So ideally what you would do is you would increase your vascular tone, and anything that gives you alpha squeeze would do that. Levo does that, but Neo does that, and Epi does that, and vasopressin does it.
That's true.
Well, the first three do it by alpha, the vasopressin does it by a different receptor,
Yeah.
but every one of them increases your vascular tone. You said you would increase their cardiac output. I would agree with that. Functionally, cardiac output is made up of two things. What are they?
Stroke volume and heart rate.
Right. Which would you preferentially want to increase?
Well, your heart rate's already going to be in sepsis elevated, so hopefully I don't think you can really increase your stroke volume, but if you could, yes.
Well, yeah, actually you can. That's what an inotrope does.
The
so,
inotrope,
so,
true.
so in a perfect world,
Fair
what
enough.
you want to do is you want to increase the vascular tone, and if their heart isn't pumping hard enough, you'd pump it harder. And if it is pumping hard enough, you would actually not want to. You'd either want it to be unchanged or not decreased. So you have a bunch of different pressors you can use. You have levo, you have neo, you have epi, you have dopamine, and you have vaso. Why would you choose them? So you're right, we use levo. We can go through this really, really quickly, what we would do. Why do we not use neo? Neo is easier to use, right? You don't need a central line. You can give that through a peripheral. And yet we typically don't start it. We typically start levo. Why don't we just start neo? Simpler.
I'm not sure.
Fair answer. So neo is a pure alpha agent, and so it gives you nothing but vascular tone. And that sounds good, but what happens is you have a reflex decrease in your cardiac output.
Okay.
So while you're trying to optimize your perfusion, not to optimize your map, you're trying to optimize your perfusion, it gets your map up, because any one of them will give you tone, but you also want to maintain or increase your cardiac output. That goes down. That's why neo, which when I trained, we actually used neo as a first-line agent. We used to call levo, leave them dead. And it was like the last thing we possibly used until we found out that that was the wrong thing to do, because neo actually decreases your cardiac output. So then dopamine works an awful lot like what I just said, right? So it increases your peripheral squeeze and it increases your cardiac output. Do you know why we don't use dopamine?
It's very dose dependent.
Well, it's dose dependent in the sense that if you give a low dose, less than 5 micrograms, it's renal dose dopamine. So it preferentially dilates renal arterioles, and it basically makes you pee. It doesn't prevent renal failure, but it makes you pee. But at a higher level, it acts a lot like levo. So it squeezes your peripherally, and it cardiac contracts your heart. So any idea why we don't use dopamine? Because we did until a couple of years ago. And for people watching this, if they're on the older side, might have used dopamine.
Is there some toxicity related to dopamine?
There is. So again, that gets down to what you're doing to the cardiac output. So every one of these, the good thing for cardiac output is stroke volume. The bad thing is tachycardia. So Levophed versus dopamine, prospective randomized trial published in the New England Journal a few years ago, comparing them, the outcomes were the same, but the people who got dopamine had significantly more tachyarrhythmias.
Okay.
So if you take your heart rate and you start at 120, and then you push it to 160 or 170, then all of a sudden you're going to A, get atrial tachyarrhythmias, and B, get to a point you can't actually fill your atria, and you have worsening problems, AFib, etc.
Okay.
So dopamine's out for that reason. How about epi?
I know that they just do use epi in some places, like I guess Australia uses epi preferentially, I've read.
Yeah, we typically don't start with epi for basically the same reason that we don't start with dopamine, which is it's going to give you, it's rocket fuel, and that's okay, you want somebody in rocket fuel, but it's going to have more effects on your heart rate than you want.
Okay.
In your heart. So that takes that epi. Epi is your sort of, depending on how you want to play it, and we're going to get to in a second or third line agent.
Sure.
Because it is the ultimate, most powerful pressor. But it does have side effects, which is why we don't start it. Okay. How about starting on vasopressin?
There are some studies that have looked into starting on vaso, but it seems that Levophed is still superior, or at least not at all different between vaso and levo.
Yeah, that's right. And so typically you start on levo, and that's the right thing to do. And so you start on levo, and you start escalating. How high will you escalate Levophed dose before you add another agent?
I guess depending on what the conventions are for dosages, but 0.15 generally seems to be a ballpark figure. It's all based on sort of the patient and the response to the agent.
When you say response to the patient, is there a maximum dose of Levophed?
No, not well. In my mind, I have a maximum dose that I won't go beyond, because then we're talking about other factors having to do with the patient's overall outcome. But no, technically, there's not really a maximum dose.
There's no maximum dose. You go as high as you need to.
Yeah.
So you talked about 0.15. You can have somebody at a levo drip at 1. At a certain point, people add additional agents because they're bothered by it. But will get as much squeeze as you'll get. So there's no maximum dose per se. But most people will start something else earlier, and I concur with that. So you said you start them at a dose of 0.15. Any particular reason?
Oh, I'm sorry.
I'm sorry. You increase them to a dose of 0.15.
Before I start a second agent.
Mm-hmm.
Honestly, no real reason other than that. That's what I've seen, and sort of that's the convention. And there are some studies that kind of suggest that renal perfusion, at the very least, if you're using it as a kind of marker of end organ perfusion, is maybe positively affected by the addition of something like vasopressin.
Okay, so we're going to get to vasopressin in a second, but just real quick, what mean arterial pressure are we shooting for?
65.
Why?
That's a really good question. I suppose that's what we've used as a general, for the general population, a good mean arterial pressure that would kind of indicate that you're perfusing your organs.
So the thing to remember is a map of 65, which is almost always, but not always the goal, is the good goal. If you want one number, a map of 65 is the right number. It's also important to remember that that's not normal, right?
Sure.
It might be, as you're sitting here, your map might be 65.
Right now, currently.
But almost every one of your patients in septic shock are going to be in their 60s, 70s, 80s. Almost every one of them is going to have hypertension. Almost every one of them is going to have a baseline diastolic that's higher than 65.
Right.
And so their map is going to be significantly lower.
80s to 100.
Right. We don't typically shoot for normal. Just like we don't shoot for most of your patients with baseline hemoglobin of 12 to 14, but we don't transfuse them up to a hemoglobin of 12 to 14. But the 65 comes in at a level that you're trying to balance two different things. You're trying to optimize perfusion while minimizing complications, right? If you push them up to their baseline map, if you push them up to a map of 90 or something, say, then you're going to be giving them substantial amounts of rocket fuel, substantial amounts of levofed. They are redistributing their blood flow, and then that's when you're going to have all the side effects of your fingers turning black and everything. So the side effects of levofed, as you go higher and higher doses or goods, are bad. And so you don't want to shoot for normal map. There's no benefit to that. The side effect of being too low is you're not perfusing your body.
Okay.
So 65 is generally the area at which you're able to perfuse your heart, your brain, your kidneys, but you're not causing significant toxicity. So it's your Goldilocks point. But that's a global thing. Is there any data looking at people comparing people maps of 65 to a higher map?
I haven't read that data, but
okay, that's fair. So there is. So there's a prospective randomized trial that came out in the New England Journal about 2 or 3 years ago, or if we see this video in the future, 4 or 5 years ago, comparing them. And what it turns out is in all people, there's no difference in outcomes. But there are 2 subtle differences that are important to know. If you push to a higher map, if you push to 85, you're going to have more tachyarrhythmias. Just like with dopamine, you're give something that has side effects and you're going to have a problem. Okay. So globally you'd say, 65 is always better, but not necessarily. 65 is usually better. But in patients who had significant hypertension to start with, 4 or 5 drug hypertension, you actually saw less renal replacement therapy in the patients who had a map of 85 in septic shock than the patients who had a map of 65.
Sure, that makes sense.
So if you start with a map of 140, 65 might not necessarily be enough. If you start with a map of 80, 65 probably will be enough. And so how do you determine what to do then? Before we're talking about adding a second pressor, what you typically do then is see how your patient is doing at the bedside. Your starting point is a map of 65. I agree with that, always. Then you assess how they're doing. If all their organs seem to be doing okay, you're probably fine. Let's say they're not urinating. Well, they could be not urinating because they're dry. You give them more fluid. They could be not urinating because they're an ATN because they were previously dry.
Sure.
It doesn't matter how much fluid you're going to give them or blood pressure, they're not going to pee. Or it could be that you're simply not perfusing their kidneys, right? And so the way to do that, the way to test that, is you push their blood pressure up for an hour at a map of 75. If they don't pee at a map of 65, and they do pee at a map of 75, they just need a higher perfusion head, and your map goal changes. And if that doesn't make a difference, you come back down to a map of 65. So 65 is your starting place. And if you want to know one number, how do you treat your patients? You treat to a map of 65. But you obviously treat the patient in front of you, and there are times where the nuance of medicine comes in. So now we have our patient, we'll say it's a typical patient, we have a map of 65, and you wanted to add vasopressin when they have a map of 0.1, when they're at 0.15 of levofed. That's a reasonable place to do it. Are there any data on the use of vasopressin in septic shock?
I think there are data. I'm not sure that it's excellent data.
No, there actually is.
There is?
There are good data on vaso and septic shock.
Okay.
So the biggest trial is something that came out a few years ago called the VAST, V-A-S-S-T trial. Because again, the New England Journal of Medicine needed a cool acronym. And what that did is it combined vasopressin with Levophed
Right.
in
So
septic
combined.
shock.
Uh-huh.
And the pre-hoc hypothesis was, because there's a vasopressin deficiency and because there's all this animal data and small studies that there's vasopressin deficiency, that you would do better when you were really, really sick. So once you got to like 0.2 or 0.3 levo, that's what we used to do. So we used to say, okay, patient's really sick, you're quote unquote failing Levophed. It's not really failing because you can go up to 0.4 or 0.5. But that's what people said, I'm just uncomfortable. This dose is too high for me. This is bothersome to me, so I'm going to add vasopressin. And the assumption is that was what was going to be beneficial.
Mm-hmm.
So when they did the VAST trial, they had a pre-hoc, because if you do a study and you're going to do a subgroup analysis, you have to determine that pre-hoc. So pre-hoc, they said, we're going to look at people on low-dose Levophed, 0.10 and less.
Mm-hmm.
I think it's 0.10, might be 0.15, and high dose, higher than 0.15. The assumption is it would have had no benefit in people on low-dose Levophed, and it was going to have a benefit on high-dose Levophed. If you read the study, it tells you that vasopressin generally doesn't change outcomes at all. So you can do it if you want to. You don't have to do it. It's up to you. If you look at the subset analyses, the people with the low Levophed requirements, 0.1, 0.08, had a mortality benefit by adding vasopressin with a p-value of 0.05. And the people on the high-dose Levophed had no benefit whatsoever. So the truth is, your number of 0.15 is a reasonable place to start it, but and of course this is nothing more than hypothesis generated because it's a subset analysis of a prospective randomized trial. But what you don't want to do is, if you buy that at all, have mission creep and say, I'm not going to start vaso until my number is 0.3 or 0.4, because if you're going to be even slightly evidence-based at all, you would start vaso early rather than starting vaso late. That still needs to obviously be finalized, that that's real or not. But if you're going to start it, you start it early. And if you look at the surviving sepsis guidelines, it basically tells you there's no recommendation of vaso whatsoever. It says you may add ungraded.
Really?
Yeah.
So does that not also, just as a sort of aside, does that not also imply that those patients were not as sick who we started the
Correct.
vaso on?
By definition, if you're on less Levophed, you're going to be less sick. But they're matched, right? So it's levo versus levo vaso, and levo versus levo vaso at really sick, it doesn't make a difference.
Gotcha.
And levo versus levo vaso when they're not so sick, it does make a difference.
Okay.
So you try that, you add vaso. That's a reasonable thing to do. What dose of vaso are you going to add?
0.02 to 0.04.
Right, so 0.03 and it's fixed. So you don't titrate
I'm sorry,
it.
yeah. Sorry,
So
it just came from Grady.
so we don't titrate in sepsis at all. Usually it's 0.03. There are some studies that it is 0.04, but we don't titrate it. So it's not a 0.02, it's not a 0.01. So you start it at Emory, at least we do 0.03 and it's a fixed dose.